بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. اللهم لا علم لنا إلا ما علمتنا. Today's subject is about the cornea. I am Dr. Gamal Bennaser from TRIPOLI-MEDICAL Center, Head of Eye Department, TRIPOLI-MEDICAL Center. I will try in this lecture to summarize some important points about the corneal anatomy and physiology and corneal diseases. And also we will speak briefly about the sclera. This lecture is intended for fourth year students, and at the end of this lecture we will wait for your reply and if you have any questions or queries. بسم الله الرحمن الرحيم. يقول المولى عز وجل في كتابه الكريم: ألم نجعل له عينين. سورة البلد. Now, the cornea is a transparent elliptical structure with a smooth surface. As you can see that the cornea is the outermost transparent part of the external coat. The outermost coat is the fibrous coat, which made up of an opaque part, which is the sclera, and the most visible or transparent part, which is the cornea, constitute around 1/5 of the outer coat. The diameter of the cornea is around 11 to 12 millimeters. It has a vertical diameter and a horizontal diameter. The vertical diameter is 11 millimeter, however the horizontal diameter is 12, and you can see that the vertical diameter is shorter than the horizontal diameter, and this will explain why most of the people they have what's known as with the rule astigmatism, and perhaps this difference in the diameter of the cornea related to the presence of the eyelids in the vertical meridians. So the presence of eyelids in the vertical meridians make the vertical diameter shorter as compared to the horizontal meridian, and that's why most of the people they have some degree of astigmatism, which is known as with the rule astigmatism. Now, the thickness of the cornea has a central thickness and peripheral thickness. The central one is around 500 microns, and the peripheral one is 1 millimeter, which is around 1000 micrometer. And this anatomical important point to know that the periphery is more thicker than the central part, so we have to be very careful when we attempt to remove a foreign body located in the center of the cornea, that you might end up by perforation of the cornea. Now, the optical power of the cornea is around 43 diopter, and as you know that all of you know that the total dioptric power of the eye is around 60 diopters. You can see that around 2/3 of the dioptric power of the eye is located in the cornea, and hence now we can modify the refraction of the patients by just changing the curvature of the cornea will make a huge difference in the total refractive state of the patients, which is known as refractive surgery. And the nerve supply of the cornea is hugely innervated by sensory nerves derived from the ophthalmic division of the trigeminal nerve, namely the nasociliary branch, and it is very sensitive structure. When we look to the anatomy, the gross anatomy of the cornea, as I say that the external coat of the eye, which is made up of the sclera, has a central foramen which is transparent, which constitutes the cornea. The limbus is a transitional zone between the cornea and the sclera, and the cornea protrudes slightly beyond the scleral globe because of the different curvatures of the two structures. The curvature of the sclera is slightly different than the curvature of the cornea. That's why the cornea protrudes forward. The radius of curvature, as I mentioned, from inside 6.7 to 9 millimeter, whereas the scleral radius of curvature is around 11.5 millimeters. So the cornea appears elliptical in shape with horizontal and vertical diameters. Now, when we go more details, now we will speak about the surface anatomy of the cornea, not just only a gross anatomy of the cornea. We'll go more details, and these details we got these informations by during the era of topography. Before the era of topography, we have little information about the detailed surface of the cornea. Thanks for this machine that gives us a lot of details about the external curvature of the cornea. So the cornea is not spherical in shape. Most of you think that the cornea is spherical. Actually, it is a prolate in shape. It's a prolate in shape with the steeper in the center and get flattened as you go toward the periphery. So we have different zones. We have a central optical zone, which is around 4 millimeter. The central 4 millimeters is the optical zone, which is almost always spherical in shape, and it goes flattened slowly as you go toward the limbus. So the central zone 1 to 2 millimeter is purely spherical, and the paracentral zone 3 to 4 millimeter, and end up by the end that merges with the sclera. When we speak on the composition of the cornea, mainly water. Around 78% of the cornea is water. The remaining is around collagen fibers, which is mainly of type 1. 50 to 55% of the collagen in the cornea is made up of type 1. The other one is with type 6, which is constitute 25 to 30%. And this is maybe an MCQ point of view, that the main type of collagen in the cornea is type 1. Other components of the cornea is the protein, the ground substance, namely the keratin sulfate and chondroitin sulfate, hyaluronic acid and salts. Now, when we want to speak in the nutrition of the cornea, before we speak on the nutrition, we should know that the cornea is a avascular structure. And when we say that it is an avascular structure, so it means that there is hardly any blood supply to the cornea. And this is a very important fact that makes the cornea transparent. There are different factors responsible for the transparency of the cornea. One of them is the avascularity of the cornea. Absence of blood vessels in the cornea is very important to keep the cornea transparent, so that there will be no shadow on the retina. Other facts responsible for the transparency of the cornea include the presence of the endothelial cells that continually keep on pumping water from the cornea, so that responsible for the corneal detrussions that makes the cornea, there is an equilibrium for the water content of the cornea. If there is excess of water in the cornea, there will be a corneal edema, and this will affect the clarity of the cornea and end up by dropping the visual acuity. Another factor responsible for the transparency of the cornea is the tight, regular arrangement of the collagen fibers in the cornea. And this tightness of the arrangement of the collagen fibers make the cornea transparent as compared to the haphazard arrangement of the collagen fibers seen in the sclera. That's why the sclera is opaque, while the cornea is transparent. So mainly we have three factors responsible for the transparency of the cornea. Absence of the blood vessels, the corneal detrussions mechanism made up by the corneal endothelial pump mechanism, and the tight arrangement of the collagen fibers. So when the cornea is avascular, so the nutrition is derived primarily from the adjacent structure, namely the tear film, precorneal tear film, as well as the aqueous in the anterior chamber. So the aqueous provide the glucose and other important nutrients to the cornea, and oxygen derived from the atmosphere through the tear film. In addition to the immunoglobulins that's present in the tear film, the important responsible for the keeping the cornea clean and free of any toxins. We have some blood vessels present in the perilimbal area, so the far periphery of the cornea, they can reach or receive some nutrition from the peripheral perilimbal blood vessels. When we speak on the layers of the cornea, we used to say that the cornea made up of 5 layers, but recently there is one Indian scientist named US discovered that there is another layer of the cornea, which is the Duas layer, what's called the predismous layer or Duas layer. So the cornea made up of 6 layers actually: the epithelium, the Bowman's layer, the stroma, the predismous layer, dismous membrane, and the endothelium. So we will come to each layer separately. We will speak on some advantages and features of each layer. For example, the epithelium, which is derived from the surface ectoderm, constitutes of 5 to 6 layers, accounting for about 5% of the corneal thickness. And this layer is capable of rapid mitotic activity. That's why any abrasions of this layer will heal rapidly. And these layers are arranged in different layers. That the epithelium arranged in different layers. The basal layer is columnar in shape. The intermediate layer is polygonal in shape, and the apical layer is squamous epithelium. And this squamous epithelium is non-keratinized. When we go to the more ultrastructure of this epithelium, the apical cells, as we see, 2 to 3 layers, hexagonal in shape. The surface layer or the surface cells contains microvilli or microplica. And this surface epithelium is not smooth, so this microplica or microvilli very important to integrate with the tear film and help in deriving the nutrition from the tear film and keep the tear film for a long time on the curve and the surface of the cornea. And the mucil layer of the tear binds with the glycocalyx and help in the uniform spread of the tear film. The next layer, which is the Bowman's layer, which is a acellular layer. This Bowman's layer is not able to regenerate, so any damage or any injury beyond the Bowman's layer will end up by fibrosis and hence lead to corneal opacity. So this layer is not able to regenerate as compared to the previous layer, which is the epithelial layer. The next layer is the stroma, which is constitute 90% of the corneal thickness, which is made up of collagen producing fibroblast, collagen fibrils, and ground substances and cells from the immune system, that's the leukocytes and macrophages. The lamellae of the stroma, now there is peculiar or special arrangement of the lamellae of the collagen fibers on the stroma, and this, as I said earlier, responsible for the transparency of the cornea. The stroma is made up of around 200 layers of lamellae, and the lamellae are arranged regularly almost in a right angle to each other, and each lamellae is made up of around 200 to 300 bundles, and this regular arrangement is responsible for the transparency of the cornea. Now the Dewey's layer or the Bredesmith's layer, discovered by Hermenders Dewey from India at 2013, and he said that the thickness of this layer is 15 micrometer, and also this layer is very strong and acellular and impervious to air. Some important landmarks or anatomical landmarks that all of you should know, which is known as the Schwalb's line. Schwalb's line is just a peripheral termination of the Descemet's membrane, and it is seen internally from the inner side of the cornea. And usually we can see the Schwalb's line using the gonioscopy. When you use the gonioscopy lens, we will see the Schwalb's line. Now, if this Schwalb's line terminate prematurely or before the limbus, so we can see it from the anterior surface of the cornea. At that time it is called posterior imperiotixion. So posterior imperiotixion is just the hypertrophied Schwalb's line, is a congenital anomaly which is seen in some cases when there is premature termination of the Schwalb's line. And both Schwalb's line and posterior imperiotixion is termination of the Descemet's membrane. The other layer, which is the endothelium, the innermost layer of the cornea is the endothelium. This layer is a single layer and is hexagonal in shape, and this layer is responsible for the corneal detrussions, that is maintaining equilibrium of the water content of the cornea. Any damage or any insult to this layer will end up by corneal edema and affecting the visual acuity of the patient. Also, this layer is incapable for regeneration. So we have around at birth, when the child born, around 6,000 cells per square millimeter, which is around 26% of this quantity is lost during the first year, and another 26% is lost within the next 11 years. And the rate of the loss is slowly stabilized at middle of age. So you can see that this layer is very precious, that we have a limited amount at birth and keep on decrease in the quantity slowly, so that any damage to this layer will decrease the lifespan of this cornea and lose the corneal transparency or clarity. So now we will speak briefly about how we evaluate the corneal diseases. Now, first of all, if we have any patient with any corneal pathology, what could be the causes of the symptoms of corneal disease? Number one, pain. The pain, usually when a patient with corneal disease will have pain, severe pain due to rich nerve supply of the cornea. Patient with any corneal disease will have some drop in the visual acuity, and maybe this because of the loss of the transparency of the cornea. Halos around the light due to the prismatic effect of the corneal edema. Patient will complain of photophobias, which is unable to concentrate on light, and lacrimation due to excessive tear production, to reflex lacrimation. Now, when we want to speak on bacterial corneal ulcers, there are some predisposing factors. As you can see that the cornea is a very precious structure and is not left like this without any protection. The initial protection of the cornea is come from the lids. The presence of eyelids offers huge protection to the cornea, and in general, presence of the eye within the pony orbit is another way of protecting the eye as a whole, and also the presence of the tear film which is rich in lysozyme enzymes and immunoglobulins will also protect the cornea from many diseases. The tight and strong arrangement of the epithelium and the presence of tight junctions and desmosomes between the epithelial cells, all these factors prevent the invasion of the organism inside the cornea. However, some people are more predisposed to corneal ulcer because of some pre-existing diseases or trauma. So we want to know what are the predisposing factors for corneal disease. The first thing is trauma. When we have in trauma, we might directly inoculate the organism inside the lamellae or the layers of the cornea. Presence of any chronic infections of the ocular adnexia, like chronic blepharitis or dacryocystitis, also this will make the patient more prone for corneal ulcer. Presence of herpes zoster or herpes keratitis, bullous keratopathy, presence of dry eye, people who are used to use contact lenses are more prone for infections, or presence of loss of sensation of the cornea, and this is another source of immunity to the cornea. Now, the presence of rich nerve supply to the cornea make it very sensitive structure, and any insult to the cornea will bring the patient immediately to the doctor to seek medical advice. So people with neurotrophic keratitis or loss of corneal sensation, they are more prone for corneal ulcers because they lose this protective mechanism. People who suffer from exposure, overexposure of the cornea due to proptosis of the eye or due to any damage to the eyelids are also prone for corneal ulcers, or the excessive use of some medications like topical steroids will make them also prone for infections. If you look to this table, the most common causative organisms, you can see that the Staphylococcus aureus and Pseudomonas in children are the most common causative organisms for corneal ulcers. The clinical pictures of the corneal ulcers, it may be differs according to the causative organism. However, we cannot depend purely on the clinical picture to have a clue or idea about the causative organism. We have to depend on the laboratory assessment and swabs and corneal biopsies to identify the causative organism. However, usually Staphylococcus and Streptococcus, they gives oval yellow dense suppuration with central corneal with a clear cornea in the surrounding. However, Pseudomonas clear with regular edges and gives necrosis and opaque cornea and very prone to perforations. This is some pictures of the how the patient with corneal ulcer or corneal abscess will appear. You can see the yellowish suppuration of the cornea in the center with reaction in the anterior chamber, which is called hypopyon, and the eye gets severely congested and also very painful. So, if we want to speak on the management generally, this is a general guidelines. If you have a patient with corneal ulcer, what are the things that you have to do? The first thing that you have to identify the causative organism. That you have to identify the organism by either scraping and sent to the lab or cultural sensitivity. you put the scrapes in blood agar or chocolate agar. Nowadays also we do the corneal biopsy to identify the causative organism. After identification of the organism, we have to start with broad spectrum antibiotics, usually with rapid frequency between half hourly or hourly. We also will give subconjunctival or subtenon injections of antibiotics. And on the top of this, we have to dilate the pupils for two reasons. Number one, to relieve the pain by creating cycloplegia, so that relieve the spasm of the ciliary body, which is an important source of pain to the patients with corneal ulcers. Another thing, that by dilatation we avoid the appearance of posterior synechia, which will complicate the picture more. If the patient will get ring synechia or occlusive pupillae, he will end up by secondary glaucoma and worsen the picture more and more. So the general guideline, we have to identify the organism, we have to give a broad spectrum antibiotic topically as well as subconjunctivally, and in some cases we give even systemic antibiotics according to the location of the lesion, especially if the lesion is near to the limbus. So we want to get benefit from the perilimbal blood vessels, so we'll give systemic antibiotics, and we have to dilate the pupil to avoid any further complications. We have to promote the epithelialization of the cornea by adding some lubricants, or sometimes we do bandage contact lenses to promote healing of the cornea. This step usually after we get control for the infections and we end up by persistent epithelial defects or corneal that have delay in the healing. So we have to promote lubrications and using bandage contact lens to promote healing of the epithelium. And in case of there is some fear of perforation or impending perforations, we can make the intraocular pressure low, and we give the patient tissue adhesive substances, or sometimes we do conjunctival flap to avoid melting of the cornea or perforations. And also we can use immunosuppressive drugs. At the end, if we are failed with all the above procedure, we can do therapeutic grafting of the cornea or keratoplasty. So the most common causative organisms that can cause corneal infection even in intact epithelium. As I mentioned earlier, that a presence of pre-existing corneal pathology is very important cause for corneal ulcer. But however, there are some organisms they can penetrate even in intact cornea, like Neisseria gonorrhea, Corynebacterium, diphtheria, Listeria, monocytogenes, and Haemophilus influenza. So we have to be careful about these organisms. If you find in your culture one of these organisms, you have to treat them aggressively, because these organisms they can penetrate and end up by corneal infection or endophthalmitis. The second important cause of corneal infections is the virus, which is herpes simplex viral infections. We have two types of virus infection or herpes simplex infection, that's type 1 and type 2. Usually type 1 we cause infections above the waist, and patients usually present during childhood with herpes labialis or conjunctivitis, and type 2 usually due to or cause infections in the genitalia. Now for primary herpes, as I said earlier, that it can present as peripheral conjunctivitis or follicular conjunctivitis or small vesicles in the lid of the conjunctiva, and gives some sort of vesicles which called Kaposi's varicilliform eruptions, and usually pass unnoticed, and usually there will be no significant morbidity after primary infections. However, some people due to defective immunity, they may have severe morbidity from the primary herpes, especially those with immune suppression. In primary herpes infection, the child is not immune for herpes simplex because maternal antibodies will not cross the placenta to the baby. So the baby, when exposed to the primary herpes, will have a subclinical manifestation in the form of mild fever, malaise, acute follicular conjunctivitis, and some lid vesicles. Rarely the cornea will be involved in the form of fine epithelial punctate keratitis, very rare, but usually conjunctivitis or keratitis or blepharitis. Now you can see in this picture that the child has very clear eruptions around the eye with the vesicles and conjunctivitis, blepharitis, So this is primary herpes. Usually it pass unnoticed, or even it will heal without even treatment, and if severe enough we'll give antiviral Zovirax to the eye or to the skin. And the significance of the primary infection, that the patient will have viremia in the blood, and the virus will be dormant and in the trigeminal ganglia, and the virus will stay there for any subsequent reactivation later on. Now, what are the factors for reactivations? Usually poor health or exposure to sun or fever will give the insult or the stimulus for the virus to replicate and reactivate. Now, the reactivation is more serious than the. Now, for recurrent herpes infection, the manifestation may varies to according to the pathway that the virus take. Now, you know that the nerve supply of the cornea goes through two plexus, the epithelial or subepithelial plexus and the stromal plexus. So if the virus follow the epithelial plexus, the presentation mainly in the epithelium in the form of dendritic ulcers or geographical ulcers or trophic ulcers. And if it follows the stromal nerve plexus, will cause necrotic keratitis or disciform keratitis. Now this table will show the details. Now the epithelial keratitis can be either dendritic ulcers or geographical. Geographical is just amplification of the dendritic ulcer. That's large, huge ulcer due to use of the steroid will end up by geographical ulcers. Marginal keratitis or metaherpetic or trophic ulcers. Now, if the stroma is involved or the endothelium, can give you endotheliitis, necrotizing keratitis, or immune stromal keratitis, or what's called also disciform keratitis, or maybe end up by keratouveitis. That's uveitis with keratitis. So recurrent infection is more serious than the primary infections. Now the dendritic ulcer is coarse dendritic branching satellite lesions involve the cornea with decreased corneal sensations. Now if this patient by mistake he uses steroids, the multiplication of the virus will be enforced and end up by geographical ulcer, usually due to topical use of steroids. That's why we used to say that steroids is contraindicated in epithelial keratitis or in epithelial herpetic keratitis. Trophic keratitis, due to recurrent attacks of dendritic ulcers, there will be continuous damage to the nerve ending and the cornea become senseless or insensitive to there is no any more nerve supply in the cornea, and the patient will end up by big corneal pathology with difficult to heal, which is called trophic keratitis with persistent epithelial defect. Now you can see in the right side the picture of the typical dendritic ulcers stained with fluorescein stain that stain the epithelial defects, and the picture on the left side large epithelial defect with the staining. This is geographical ulcer. So the right is dendritic and the left is geographical ulcers. The same thing, 50% they will heal even without a treatment, but we if we want to treat, we'll give aceclopar, topical antiviral treatment with debridement if there is debris at the edge of the ulcers, or patient with trophic keratitis that retard the healing of the epithelium. At that time we can do debridement. There are different modalities of antiviral treatment, but the most common is the aceclopar. I mentioned here different types of treatment, but aceclopar will be sufficient and do the job. For stromal keratitis or stromal involvement, as I said, if the virus follow the stromal nerve plexus, now the virus will find itself embedded within the stroma and infiltrating the stroma. Usually there are two main manifestations, either severe necrotizing keratitis necrosis within the stroma caused by the virus body itself or the virus particles itself that proliferate, maybe super added by bacterial infection or fungal infections. In this case, we need to give intensive antiviral treatment, and we have to give steroids. If there is a stromal involvement without epithelial involvement, we have to give steroids to minimize the defect that will happen within the stroma. And if the damage is severe in the stroma, the patient will end up by severe corneal opacities. Now, antibiotic, accordingly, if we feel that there is super-added bacterial infection, we can add antibiotics. Now, if the involvement goes deeper to the endothelium, the patient will present with endotheliitis with overlying stromal edema. So, will lead to endothelial dysfunction. This is called endotheliitis. Okay. This endotheliitis will gives a disc-shaped area of corneal edema, and sometimes named as disciform keratitis. So disciform keratitis is well circumscribed, localized edema of the stroma overlying and infected endothelial cells, and usually this is immunological reaction rather than real invasion of the virus particle itself. That's why the mainstay of treatment here is steroids. We don't need antiviral in this type of infections. This picture shows the different types of the stages or different stages of herpetic keratitis, ranging from corneal ulcer to severe melting of the cornea with impending perforations and descemet membrane bulging descemetocele, with the picture in the left lower corner, diffuse corneal opacities with vascularization of the cornea and nearly in the stage corneal opacity. In some cases, for some reasons, the patient will have keratouveitis, that is severe uveitis along with the keratitis. And this type of uveitis is granulomatous uveitis, and these patients, they will need systemic antiviral treatment in addition to the topical antiviral, and we have to monitor the case closely, especially for the appearance of glaucoma. This patient might need anti-glaucoma treatment as well. Now, the second type of corneal herpetic infection is the herpes zoster, which is the counterpart of the herpes simplex. Also, this is a DNA virus, and this herpes zoster also present in two stages during childhood in the form of varicella shingles or chickenpox, and when become dormant in the spinal ganglia, later on reactivation appears and present as varicella zoster or herpes zoster ophthalmicus. Usually this type of reactivations is associated with elderly people and those with immune suppressions or exposure to chemotherapy or radiotherapy, and usually is associated with a skin lesion. And if you remember, during herpes simplex, in the primary infection of herpes simplex, there is a skin manifestation, but in the secondary herpes there is no skin manifestations. However, in herpes zoster, the skin manifestation is present in the secondary or reactivation stage. The same thing, the viral will follow the nerve, the trigeminal nerve, and involve the eye by involving the nasociliary nerve. And what's known as Hutchinson sign is the involvement of the tip of the nose. If you find the tip of the nose involved, this means that the eye is involved. However, if you don't find the tip of the nose involved, this does not rule out involvement of the cornea. The same thing, herpes zoster can have skin manifestation or ocular manifestations, skin in the form of maculopapular skin rash or vesicles, ocular manifestation ranging from small dendritic ulcers, superficial punctate keratitis, nummular keratitis, disciform keratitis, or neurotrophic keratitis. You can see that there is a close similarity between herpes simplex and herpes zoster. The difference in the nummular keratitis and superficial punctate keratitis are common with herpes zoster. And the treatment ranges from antiviral, topical steroids, and we have to give steroids in post-herpetic neuralgia. There is post-herpetic neuralgia. Now, the peculiar thing about herpes zoster is that no structure within the eye is immune against herpes zoster. Any structure in the eye can be involved. If I ask you what are the ocular manifestations of herpes zoster, you can close your eyes and keep talking like this: keratitis, uveitis, trabeculitis, vitritis, retinitis, choroiditis, optic neuritis, myositis. Every structure in the eye can be involved by herpes zoster. However, the most common manifestation is corneal involvement, that is keratitis. However, no structure is immune in herpes zoster, unlike herpes simplex. Herpes simplex mainly keratitis and maybe keratouveitis, but other structure really is involved, rare. Also retinitis or retinochoroiditis is rare in people with immune suppressions. Now, this picture you can see in skin rash, old patients with red eye. So this is typical of herpes zoster involvement. This is dendritic ulcers. This is old atrophic lesions of the iris, that's called scalloped lesions of the iris. and this is indicating old involvement with herpes zoster. Fungal keratitis is rare, but nowadays we can see them in due to trauma, mainly when the patient gets trauma with organic objects like the wood or a tree. This we should keep this in mind. Another thing, we used to see these cases in people who frequently use steroids for a long time, like people after post-keratoplasty, or people with severe allergy that they use steroids for a long time. Also, we should keep this in mind. If your patient is not responding to your medication, you use antibiotic, antiviral, and there is no response, you should keep in your mind fungal keratitis. Fungal keratitis can be in the form of filamentary keratitis or yeasts, filamentous keratitis or yeast. Of course, this be apparent by microscopic examination or by staining, special staining. We use special staining to see the hyphae of the filamentary keratitis, filamentous keratitis, or by gram staining also. So the management, we have to do gram staining, Giemsa staining actually, and see if there is hyphae or yeasts. We can grow in subarachnoid media or blood heart infusion media. Now another entity or another type of keratopathy, which is named as exposure keratopathy. In exposure keratopathy, there is excessive exposure of the cornea, and there are some reasons for this exposure of the cornea, especially facial nerve palsy. People with facial nerve palsy, they will have lag of thalamus and they will have overexposure of the cornea. People with severe proptosis or with severe cicatricial eyelid disorders, and these people, they will expose their cornea and get dry and superadded by bacterial infections. Usually patients will present with severe pain and if long-standing and chronic, with vascularization and end up by perforations. This patient has facial palsy of the right side, lower motor neuron lesion, facial nerve palsy of the right side. You can see that he cannot close the right eye and the mouth is deviated to the normal side, that's the left eye. So this patient is prone for exposure keratitis. Another point is what's known as Pill's phenomena. Now, Pill's phenomena, when you attempt to close your eyes will roll up. And people with exposure keratitis, they used to have the inflammations or the keratitis in the lower 1/3 of the cornea because of this phenomena. Absence of this phenomena will make the exposure keratitis involve the whole eye. But about 80% of the people, they have positive Pill's phenomena, so the exposure will be mainly in the lower 1/3. So you should keep this in your mind. And the treatment primarily towards the primary cause of the exposure: artificial tears, bandage, contact lens, frequent ointment applications, and sometimes we need to do lid tapes or sometimes surgery to avoid the cornea from being infected or perforated. Another important entity is the keratoconus. Keratoconus is a form of corneal dystrophy that involving young generations, and especially boys, more common in boys and in black people. And it is characterized mainly by two features: that's thinning of the cornea as well as ectasia or bulging of the cornea. So the main hallmarks of keratoconus is thinning and bulging, usually bilateral, but sometimes asymmetrical, that involve one eye before the other eye. So the patient will present by frequent changes of his glasses due to early astigmatism. On slit lamp examination, you will find some vertical stress lines called Vogel's lines, and you will see prominent nerves, corneal nerves, due to thinning of the cornea. And in advanced and severe cases, you will see Manson's sign positive when the patient looking down, and iron deposition around the base of the apex of the cornea, which is called Fleischer's ring, and in some cases present acutely as acute hydrops when there is sudden break in the distal membrane with influx of the aqueous within the cornea. This will cause stretch of the cornea and severe pain. The patient will present with severe pain, this condition named as acute hydrops. Now you can see in this picture the different stages of keratoconus, ranging from very mild oil droplet reflex in the left side of the dilated pupil in the red reflex, which is called oil droplet reflex or Caesar reflex by retinoscopy, And to the end lower right corner, the acute hydrosis with corneal opacity and severe pain in that case. And where the picture in the right upper corner, when the patient attempt to look down, there is a positive Manson sign. Lateral view also, you can see the bulging of the cornea. This is keratoconus. The importance of the keratoconus that it involves a young generation who's actively in the community, so it will affect their vision. The second important thing that it is cause of reversible blindness. It is a cause of reversible that if we pick the case early, we can manage it successfully by preventing further progression using cross-linking or by managing it early before it reaches to the stage of keratoplasty. In these cases, we are not eager to do keratoplasty. We have to prevent the progression of the disease. But at certain point, the only solution for these cases is keratoplasty. Now, what are the different signs that you can see? The patient will have present with the progressive myopia and irregular astigmatism, what's known as the Risotti sign, which is when we throw the light from one side of the cornea, there will be shadow on the other side of the cornea. Manson sign, this is a very late sign, oil droplet reflex, by direct ophthalmoscopy, scissor reflex, by retinoscopy, scarring of the Bowman's layer, and so forth. Now, there are different modalities for the detection of keratoconus, ranging from the simple primitive tools, that is the retinoscopy, and by slit lamp and keratometry, and advanced tools, that's the corneal topography. Actually, during the discovery of the corneal topography, we came across to a new entity of keratoconus, the subclinical keratoconus, so that we can detect keratoconus in very early stages, even before it becomes evident clinically. So just for your knowledge, that we can detect keratoconus by retinoscope, by slit lamp, by keratoscope or keratometry, and by topography. And there are different modalities of the classification. This is a clinical classification of keratoconus according to the shape of the cone. Can be a nibble cone when this is central, oval cone, or globus cone that's involved the whole cornea. If the whole cornea is involved, it's called a globus cones. This is clinical classifications, because there is another classification based on topography or keratometry. Like this, when it is mild, less than 48 diopters, or moderate, between 48 to 54 diopters. This is the dioptric power of the cornea. So we have two modalities of classification: clinical classification and classification based on keratometry. Another point that you should know that keratoconus may be associated with other systemic diseases like Down syndrome, Marfan syndrome, Turner syndrome, Ehlers-Danlos syndrome. So you should make sure that your patient is not one of these syndromes. Now, what's the management of keratoconus? Actually, our aim should be oriented towards picking up keratoconus in the subclinical stage by the advantage of topography. In that stage, if we pick up the case very early, we can handle it properly by doing cross-linking and prevent further progression of the disease. However, if you detect it lately, that already the patient became clinical, our management will range from glasses to contact lenses, and in advanced stage by keratoplasty. Now, I wrote this term, that's epikeratofakia. This, you might find this term in any of the old boxes. Nowadays, this epikeratofakia is not done anymore because of the evolution in the keratoplasty, so we don't do any more epikeratofakia. And some medical management, in the presence of acute hydrops, we will use hypertonic saline to decrease the corneal edema and to relieve the pain of the patients. Keratoplasty, we have to speak about keratoplasty as one modality of the management of keratoconus, and another indication of keratoplasty in the presence of corneal opacity. So we can classify the indication of keratoplasty into optical indication to improve the optical state of the patient, like in keratoconus; tectonic, to keep the shape of the eye, to preserve the shape of the eye; therapeutic indication, when we have malignant corneal ulcers that is not responding to any medical treatment. At that time, we have to cut the cornea and do a new cornea, that's keratoplasty; or cosmetic reasons, when a potential for useful vision is not there, so we have to just remove the corneal opacity and put transparent cornea. So keratoplasty can be one of these indications, and generally keratoplasty can be classified into penetrating keratoplasty and lamellar keratoplasty. When we say penetrating, we mean full thickness, that's all the layers of the cornea is changed, while lamellar keratoplasty, that we preserve and keep the endothelium of the patients and just penetrate the superficial layers. Also, another thing, we have some advantages or some criteria for the donor cornea. Now, the donor cornea, the patient who we will take the cornea from him, the cornea should not, after the death should not be more than 6 hours. This is called the time elapsed since death. Should not exceed 6 hours. Before 6 hours, we can take the cornea. After 6 hours, usually the success rate is very low. And the younger the patient, the better the result. And the dead patient should not die from any unknown CNS disorders or any presence of any malignancy in the body or any intraocular surgery. All these are contraindication for the donation of the cornea. Presence of any intraocular surgery or death for unknown reasons, or presence of any malignancy in the body, or any CNS disorders for unknown reasons. This is the criteria for the donor cornea. Now, the recipient cornea, that's the patient that we want to implant for him. There are some favorable points. If the opacity is localized, especially those with keratoconus or with corneal dystrophies, this carries a good prognosis. However, those with vascularized cornea, with a dry eye and loss of sensations and severe inflammation of the eye, they carry a bad prognosis. So what are the good criteria is the central localized corneal opacity without vascularization, without dryness. A relative contraindication is loss of corneal sensation. Some people, they say that, for example, by loss of corneal sensation, we mean herpes simplex. If we are afraid that the virus will disseminate after keratoplasty, at that time we cannot do keratoplasty. However, some people, they advise to use systemic antiviral and then do keratoplasty. So the unfavorable prognosis is loss of corneal sensation, dryness of the cornea, and presence of corneal vascularity. Some other poor prognostic factors that we should avoid in a patient when we want to do keratoplasty is the presence of uncontrolled glaucoma, or presence of arteriosynechia, or presence of uveitis, or any chronic adnexal disease affecting the tear film, or very young patients. Very young patients also carries a bad prognosis for keratoplasty. Complications of keratoplasty during surgery, early complication immediately is the flat anterior chamber, iris prolapse or infections, and late complication after 6 months, glaucoma, astigmatism, and wound dehiscence or wound separations, and cystoid macular edema, and recurrence of the same disease in the implanted corneas. For example, if the patient implanted because of corneal dystrophy, you might discover that the new implanted cornea also have corneal dystrophy. There is one term you should know that's called graft failure. Now, there is a difference between graft failure and graft rejections. And graft rejection is immunological reaction due to antigen-antibody reaction leading to attack of the body attack the grafted cornea, so lead to failure of that graft. However, graft failure is very early due to bad handling, bad manipulations of the graft. The criteria of the graft is not suitable. The endothelium of the graft is not good. So immediately after the surgery, the patient will have unclear graft and corneal edema, and this is called graft failure. So graft failure is not due to immunological reaction primarily. We treat graft failure by topical steroids. We give systemic steroids or subconjunctival steroids in the hope that we will recover that graft. This slide shows the different complications that arise from keratoplasty. In the left upper corner picture, you can see the endothelial rejection line, and the lower left corner picture also see KBs and rejection lines and endothelial infiltrates. So the most important complication of keratoplasty is corneal rejections, which can be epithelial rejections or endothelial rejections. So lamellar keratoplasty, it carries a better prognosis. Why? Because we preserve the endothelium of the patient. Then now the endothelium of the patient is the most antigenic part of the cornea. So if there is antigen-antibody reaction, mainly will be directed towards the endothelium. So if we keep the endothelium of the patient and implant the other layers of the cornea, now the prognosis will be better. Usually we do lamellar keratoplasty when there is superficial corneal opacities or recurrent pterygiums, limbal dermoid or desmatoceles. Now we will speak briefly about the sclera, which is the opaque part of the fibrous part or fibrous coat of the eye. The sclera composed mainly of collagen bundles of different sizes. As I mentioned earlier, they have haphazard irregular arrangement of the collagen fiber, and it constitutes 5/6 of the globe of the eye. And usually the sclera associated with inflammations of the connective tissue diseases. If the patient has any connective tissue disease, we might have inflammation of the sclera as well. And the blood vessels supplying the sclera mainly come from the conjunctival blood vessels or superficial blood vessels or deep blood vessels. Now episcleritis, which is benign lesions, usually recurrent, can take the form of small nodular episcleritis or diffuse episcleritis. Patient will present with localized redness and watering the eye. Usually this is benign problem, resolved might spontaneously or with topical steroids or non-steroidal anti-inflammatory, and even treatment is not always required. In contrast to scleritis, which is less common. Now scleritis is more serious, but it is less common as compared to episcleritis, and usually common in women and in old people, and the main presentation is severe pain. The pain in scleritis is more severe than the pain in the episcleritis, and it can be associated with herpes zoster or connective tissue disease. Now, connective tissue disease is associated with scleritis and is not associated with episcleritis. If your patient have connective tissue disease like rheumatoid arthritis or polyarthritis nodosa, SLE, all these cases may be present as scleritis. So, as I said, that scleritis is less common than episcleritis, but it is more serious because the complication of scleritis may end up by melting of the sclera and staphyloma and even perforations. So this table shows the different types of scleritis, ranging from autoimmune diseases to granulomatous diseases. This is the list of diseases. Now you should keep this in your mind because this is might come as MCQ. What are the autoimmune diseases associated with scleritis and the granulomatous diseases like TB, syphilis, sarcoidosis, leprosy? And scleritis can be classified into, according to the anatomy, anterior scleritis and posterior scleritis, and the anterior one can be necrotizing or non-necrotizing. The non-necrotizing is the more common, which is diffuse and nodular, and the necrotizing, which is more serious, is less common. Always when there is serious thing, it is less common. When there is less serious thing, it is more common. So scleritis, because it is serious, it is less common than episcleritis. And among scleritis, the necrotizing one is more serious, it is less common than the non-necrotizing one, which is less serious. And anterior and posterior, because the posterior scleritis is more serious than the anterior scleritis, so you can see that 98% of the scleritis is anterior, only 2% is posterior. This is the same thing. So as I said, that anterior scleritis can be necrotizing or non-necrotizing. The main feature of the anterior scleritis is pain, and there is no much drop in the vision as compared to the posterior scleritis. In posterior scleritis, because it is near to the optic nerve, to the macula, so drop of vision is more frequent. Another point, topical steroid is contraindicated in scleritis because you will enhance melting or thinning of the sclera. However, we treat them by systemic steroids, and if severe enough, we will add cytotoxic drugs or immunosuppressant as well. This is the same thing. This is the picture of severe necrotizing scleritis. You can see severe redness of the sclera with patches of ischemia, white patches due to necrotizing scleritis. Now you can see here in advanced and stages of scleritis, there's melting of sclera and exposure of the ciliary body and the choroid, which is called staphyloma, and this patient is impending for perforation. The treatment usually by oral steroids, and if severe enough, we will add cyclophosphamide, azothioprine, and cyclosporine, or combined therapy with IV methylprednisolone, according to the severity of the case. This is severe necrotizing scleritis with melting of the sclera. You can see the bluish discoloration of the sclera above the limbus, and which is called, if there's no redness, called necrotizing without inflammation, it's called scleromalacia perforans. This is common rheumatoid arthritis. Posterior scleritis, as I said, because it is near to the optic nerve and the macula, a patient may present with drop of vision. Pain is less, but drop of vision mainly may present with retinal detachment, oxidative retinal detachment, or with the proptosis. So posterior scleritis is less common as compared to the anterior scleritis. It is more serious than the anterior, and vision threatening here and posterior scleritis more than the anterior scleritis. Same thing in treatment by systemic steroids. Thank you very much. I hope by the end of this session I highlighted some important points about the cornea and about the sclera, and I want you to forgive me if there is any missing points, because the subject is very long, and you are welcome for any questions. You can ask me anything you want. Thank you very much.